But let me get on, because we're talking about pharmacotherapy here. In your experience, Dr. Handelsman, how late are initial diagnoses being made, and how often then is a pharmacotherapeutic regimen actually necessary in conjunction with lifestyle changes, yes, by the time a patient's initially diagnosed? I guess what I'm saying is you find them, and by the time you find them, you're already putting them on drugs.
You know what? That's a time for me to put a very important concept that I call personalized medicine or individual goals, because I think it's very important. I don't think all patients are the same and they're being diagnosed at different times. Somebody can be diagnosed 3 years later and somebody 12 years later. One would have an A1C of 11.5 and one would have an A1C, let's say, of 7.5. I think they have to be treated differently. And I think it's very important that we recognize that. Lifestyle is a definite part of that. But then I believe on the day of diagnosis, when I see them, lifestyle is not enough. I will give them a medication, whether it's just metformin, but if their A1C is very high, I may give them more. If they're very symptomatic, I may have to give them insulin just at the beginning because they have a way to go.
Well, and there are so many unknown variables with regard to the trajectory of a disease state. So you could have someone who has an A1C of 11.5 and another one who has an A1C of 7.5, who that person with 11.5 gets the message, says, wow, they go out and lose 50 pounds. They go only on metformin. They change their lifestyle around. They become active. And their problem is in many ways not solved, but they've taken ownership and corrected it. You take that person at 7.5. They don't lose any weight. They're on 3 medicines. They haven't changed their lifestyle at all. And their A1C may slowly rise.
So you agree with me that we cannot fight gluttony? I mean, that's what I said before. But I think the point is, in our experience, the patient you describe with only metformin, A1C of 11.5, it's very rare to get to goal. Right. I'd start with a couple of medications, maybe insulin, get them to go, and then I'll pull back. We can always pull back.
Let me ask this question again. What is the prevalence of prediabetes versus late-stage disease in this country?
Oh, prediabetes, as we said, the numbers from 2 years ago were 80 million. So you're looking maybe today now close to 100 million people with prediabetes. Late stage, so diabetes itself, you said 26 million, maybe 30 million. So we are looking perhaps at 5 million at late stage. So it's really quite a
disparity. It's quite a spread.
It's a 3-to-1 ratio of pre-diabetics to diabetics.
There's also one other question. I just want to put this on the table. There's so many. I'm so glad I've got you all here. There is this sense among the American population and many physicians that drugs per se are bad. That if we could only treat with lifestyle and fight gluttony and exercise, we wouldn't need these bad drugs. What is so bad about a statin, maybe some metformin, and we get things under control?
Hold it. That's not the population I deal with. The
Tell
population I deal with thinks a pill is the answer.
Right.
They think, give me a pill, doc, just don't give me the needle. Give me a pill and that'll fix everything. I don't have to change my lifestyle. And that holds not just for diabetes, that holds for lipid disorders, that holds particularly for obesity. I want to get my pill to lose weight, or more so, I want to go have surgery because that will fix the problem. No matter how much I counsel them that 5 years from now, unless you change lifestyle, the weight you've lost, you will gain back, and then some. So I would argue that our society values the pills more so than other societies.
However, at the same time, the real people that really like the pill are the lawyers. And so for every drug that has a minimal and a potential, a small headline, maybe there is a side effect, immediately the emails and the headlines are bombarded with, call me because you may have a case.
And with that, I'm gonna throw this back to Dr. Weber, because malpractice is not where we're going on this particular broadcast. But you can all come back and discuss that if you'd like. But Dr. Weber, what I'd like you to do is discuss the therapeutic challenges associated with late disease patients with cardiometabolic disorders.
It's not uncommon for people to show up to a doctor's office with previously undiagnosed or unrecognized risk factors. That's something that happens a lot: high blood pressure, lipid disorders, even diabetes. But what surprises me, are the number of people who come in who've already had an event, maybe a silent myocardial infarction when we look at the EKG, or they've got atrial fibrillation even that they didn't recognize. Or when you look at renal function, you see that they've got a GFR that is surprisingly low. They've already got what is called stage 3 chronic kidney disease. All of those things are very troubling because once you've had an event, once your kidneys reach a certain level of dysfunction, the risk of something further happening, a really major bad outcome, goes up quite dramatically. And when we see that, we really have to roll up our sleeves and work very aggressively at controlling those patients because they truly are at a very high risk. And clearly, now is the time to get all the risk factors under control that we can deal with, also prescribe with a view to doing the best we can to protect the kidney, also prescribe with a view to do the best we can to protect the heart, even beyond dealing with the risk factors that we've been talking about.